Okay, why don't we get started where we left off before. We're talking about the surgery for the retinaculum. So, Michael, why don't you take this case?
Okay, so follow-up post-op. So this one looks like I see kind of a big defect in the flexor retinaculum. Pretty large. The median nerve, if it's there, is very indistinct. Like I don't really see its borders nicely. So, I'm wondering if there's, if the median nerve is injured. Like I don't really see it on these cuts, unless this is just low field.
I don't think it was injured, but I think you have some scarring around there.
Okay. Yeah, but I don't see like complete scarring down of the retinaculum.
Okay.
Do you see the retinaculum?
No, there's a big defect in it.
So this is 102104. This is now 42505.
Okay, so now it looks like it looks like there's just now an intact thickened retinaculum, which is going to be a bunch of scar tissue in that. So it's just kind of basically scarred over and reclosed.
Right. Which is
one thing that Campbell's was talking about, I've been reading about it, John, is that it's hard to tell whether, clinically at least, that you're dealing with a retinaculum or scar tissue. They look very much the same. And that's one of the problems when you're operating on these cases.
okay.
And Campbell's doesn't really recommend MRI, but they go along with it if you're having difficulty figuring out what to do.
Okay.
So,
So again, this is a carpal tunnel post-op. You can see a defect along the at the hook of the hamate between the flexor retinaculum. There's a little bit of enlargement of the median nerve right there, and there's some scar tissue, but not too bad.
Notice the edges are not very smooth; they're a little stellate. This is typically what occurs when the scar attaches to the nerve and retracts.
Okay.
And is often seen when you get recurrent symptoms.
Okay.
With nerve involvement with the scars, so it's not what we like to see. But it also doesn't correlate real well with symptoms. So, but anyway, and following up quite a lot of these after different kinds of median nerve surgery, it is very common to see extensive scar tissue, and some people are scar formers and some aren't, around the median nerve, and it was not uncommon for the symptoms to recur at that particular time, though not always. The bottom line is these aren't done very much anymore because the outcomes were not very good.
19% recurrence of surgery.
19 recurrence of what?
Carpal tunnel. The recurrence of the problem is 2%, but surgery is higher. I don't know why.
Yeah. Okay. Yeah, well, right then, as I said, about 7 or 8 years ago, insurance stopped reimbursing for most of these, so the volume of carpal tunnel dropped precipitously in California to almost zero. So moving on to other areas, let's talk about the area around the pisiform, which can have somewhat complicated anatomy here. So we have the flexor carpi ulnaris tendon, which comes forward, comes volar to the pisiform, is kind of attached down here by a fibrous tissue, and then continues distally to attach to the base of the first, typically. Then you've got the adductor digiti minimi muscle with its tendon attachment, the extensor retinaculum over here, the flexor retinaculum in through here. And here's the ulnar margin of the flexor retinaculum. So this is just another kind of diagram of the adductor digiti minimi. You've got a number of capsular attachments here, including the pisiform metacarpal ligament. You've got the pisiform hamate ligament, the flexor carpi ulnaris tendon in this location, and then the flexor retinaculum in through here. Okay, Elior, what do you think of this case?
I see some increased signal just proximal to the, I think it's the ECU tendon going over the pisiform, or proximal to that. It's
So we don't see the ECU down here.
right.
This is actually it coming over with a fibrous attachment to the pisiform, and here's the distal pisiform metacarpal ligament, distal extension of the flexor carpi ulnaris in that location. Here's a normal pisiform hamate articulation, and then we can see the hook of the hamate right there. So it just kind of shows some of the basic anatomy there, and we're out of the plane of the tendon down here is the reason we're not seeing it very well. Michael, what do you think of this case?
Sorry about that. So I guess it says, unstable pisiform. So what we see is the pisiform articulation with it, it's pretty angulated anteriorly or volarly, like about approximately 45 degrees compared to the triquetrum. So, like partial dislocation.
Okay, so
and then I guess there's got to be so that ligament that we were seeing, the pisiform ligament to the base, the fifth metacarpal is now, I don't see it. It looks disrupted.
Right.
And then the F's, and I guess it's getting pulled on by the flexicarpial ulnaris, and that's what pulls it and angulates it.
Yeah. So these were tears of the pisiform metacarpal and the pisiform hamate ligaments more distally, which then allowed proximal angulation of the pisiform. And this is kind of an unstable pisiform. And I think there are measurements I'll show you in a minute where you can measure this angle. Let me see if we, okay, here's another example where here's the flexor carpi ulnaris tendon, and then we see a lot of increased signal intensity within the distal pisiform hamate ligament in that location. And if we follow it over here, you can see that it becomes very thickened and increased signal intensity. So this is more proximal in through here, in this area here. And this was a tear of the flexor carpi ulnaris tendon. And here more proximally, we can see it's intact. So that was a tear here of the flexor carpi.
Laceration, John?
What, John?
Is that a laceration type of situation?
I don't remember the history in this particular case.
Is that B12? I was telling the fellows that I have a B12 deficiency. That's why I'm anemic. And they say that you become goofy if your B12 is below 400.
So what was the size of your red cells?
300 is my B12 level. 11 grams. Hemoglobin is 11.2. I remember I'm following in your footsteps, and it's supposed to be the other way around. I'm older than you.
So the patient has a painful mass after basketball. We see the skin marker overlying the flexor carpi ulnaris, and then you can see on the fluid sensitive sequences there's increased signal within the muscle. I don't know. It seems like the muscle is extending a little bit more than I normally see it, but maybe a little bit. But there is definitely some tendinosis of the tendon and some strain of the muscle.
Okay. Now, in this particular area, looking at further anatomy, there's Guillen's canal, which is on the ulnar aspect of the carpal tunnel area. Here's a flexor carpi ulnaris. Well, let's just go through these. So this is coming in. This is a little bit So here's proximal, and as what we're seeing here are artery, veins, and nerves. And here's the flexor carpi ulnaris tendon. And then these are fat surrounding it. This is the carpal tunnel over in this area. And if we go a little bit more distally, again, we can see the artery. We can see veins, and then we've got nerves going deep and deep part of the Gans canal and the superficial portion of the Gans canal, external to the carpal tunnel area. And then if we could go further, we're at the level of the hook of the hamate. So there are groups of nerves and vessels adjacent to the hook of the hamate, deep to the muscle. And then we got nerves, artery, and veins superficially, which is a superficial component of Gans canal at the level of the hook of the hamate. So in looking at Gans canal, we have the ulnar nerve, which is coming down through here. Then we have the pisiform bone, the hamate, which is deep in here. And then we've got the ulnar artery, the median nerve, and in this particular case on other locations. And notice that the vessels come down and then make an arc here, and then you've got the digital vessels coming off of that. So this is the area of Gans canal, right in through here. Let's see, who's next? Okay, so here's a patient who, I don't remember exactly the history here, but let's just say he was at home and came in with pain and a palpable mass in the palm of the hand.
Okay, so we have axial images through the wrist. There's a skin marker on the volar aspect. I do see some high signal intensity in the area of the Gans canal. Yeah. Not sure what it could be. Oh,
so this is called Hypothenar hammer syndrome, and this is a traumatic aneurysmal artery there due to repetitive trauma commonly seen in camera operators or carpenters who use their hands a lot, and this is a repetitive trauma-induced aneurysm, really, of the artery.
That's not unusual, and thrombosis is not unusual, and aneurysms are not unusual.
Okay.
Probably know about this.
Good. Okay, Michael, what do you think of this case? Michael?
Okay, so yeah, so we see this kind of circumscribed elliptical, markedly like IR hyperintense. Looks like a mass. It's kind of it's like on the proximal aspect of the wrist. This is going to be like down at the kind of distal radius, ulnar, and it's on the. This kind of looks like a schwannoma.
Okay.
Regular increase. And we're looking, and it's right underneath that flexor carpi ulnaris. So I'm guessing it's ulnar nerve schwannoma.
Yeah. So this is an ulnar nerve schwannoma, which can look a lot like Hypothenar hammer syndrome. But
this would be a little too this would be more proximal though, right?
Right. And then, but here, well, it doesn't have to be. It depends on where it's located because the nerve goes.
I mean, compared to like the Hypothenar hammer syndrome, or can you get findings that proximal for?
This is a little proximal for that. You're absolutely right. And there we can see the fusiform appearance of the nerve going in and out. So that's a schwannoma.
All right. So at the level of the Gans canal, you see heterogeneous soft tissue, a little bit increased signal there. It's kind of just deep to the flexor carpi ulnaris. It's following the course of what I assume to be the artery, but it's just a hemangioma. Okay.
So in Guillen's canal, I'm seeing a well circumscribed, hypointense structure. Looks like a tendon, really. Does it connect to the pisiform there? Yeah, I don't know. Maybe some kind of.
Yeah, this is tenosynovitis of the flexor carpi radialis.
Oh, okay.
Should be the Ulnaris. We're on the opposite side here. There's a pisiform. So this is on the opposite side now. So we switch side. This is a flexor carpi radialis tenosynovitis, and we're on the radial side here. Okay, Michael. So we're no longer in Guillen's canal on that last one. Michael, are you with us?
Yes. Okay. So there's a extreme amount of fluid within a tendon sheath, which looks like this is going to be the. Is this also going to be the flexor carpi radialis?
Here's the radius, and there's the ulnar.
Yeah. So I mean, it'd be marked tenosynovitis, but the tendon itself actually looks pretty, sharp and intact.
Okay.
All right, so approximately we see the flexor carpi radialis, and it looks like there's minimal increased signal there within the tendon and some fluid, and then distally it seems torn, or absent, so it's probably a tear of the flexor carpi radialis, and it's discontinuity on the sagittal sequences. I don't really see it very well, at least partial, high-grade partial tear. Yeah.
Okay, 70-year-old female, pain and numbness 1 week after injury on golf swing. Okay.
Well, if you go out and exercise, you injure yourself. If you don't exercise, your joints fall apart.
Seeing edema around the ECU with some subluxation of the tendon. There's also some volar displacement of the. Is there some volar displacement of the radius compared to the ulna?
Maybe, but this might be within normal limits because there's some variability there. But I don't really see a good capsule
here. Seeing some fluid there around the tendon. Just maybe some tenosynovitis or rupture radialis. Okay.
Here's the proximal end. Here's the distal end, and this is all displaced. This was a rupture with proximal retraction. Michael.
Okay, so we see a lot of fluid within the tendon sheath and significant, on the first image, proximal and thickening of a tendon. I was going to say flexor carpi radialis, but is that that's the flexor pollicis?
Well, this is the radius, and that's the ulna. Yeah.
That's right there that you just pointed to. That's the flexor carpi radialis, correct?
Yep.
So that'd be the flexor pollicis longus, and then distally it's not there, so tear of the flexor pollicis longus. And now sagittals, yeah, we can see it's completely torn and proximally retracted.
Good.
Are we following the flexor pollicis longus and there's some fluid within the tendon sheath? Okay. Pain in the palm. Okay. Is there just, I don't know, is that fluid within the radial and ulnar bursa, or is there okay, so there's some edema within the intrinsic muscle there, palmar okay, so it's torn. Okay, it's really hard to see.
Yeah, just it's a grade 1 muscle strain.
I'm seeing increased signal around the flexor tendon on the second digit there. Some tenosynovitis of flexor tendon.
Michael? Michael, are you still with us?
Yes. Yeah. So I'm seeing quite a bit of edema in the thenar muscles. So I'll see at least a grade 1 strain of these muscles.
Yeah. So that's a grade 1 strain of the thenar muscle. Good.
So what is this 66-year-old female's presenting complaint? Looking here, there is some suggest. It looks like the tendons aren't quite what I'd expect. There seems to be some absence of some tendons there. Distally, I see some normal tendons there, so I'm guessing they're distally they're ruptured, or they're not. Yeah, he can't bend. He can't flex. She can't flex her fingers. There's a lot of tears of the flexor tendons throughout.
Go back. You're missing tendons over here. Right. Yeah, sometimes it's hard to see something that's not there. Sometimes if you know the history, then it's fairly easy. Otherwise, sometimes you might have to count just to make sure you're not missing something. So let's talk about the flexor tendon anatomy. So here we can see that the flexor digitorum profunda is the more dorsal of the tendons proximally, but it penetrates the flexor digitorum superficialis at the level of the proximal phalanx, and then extends distally to insert at the base of the distal phalanx. The flexor digitorum superficialis in the palm of the hand is superficial, but then it becomes deep where it attaches to the base of the middle phalanx, so that you can get proper flexion of the tendons. And then you can see that there are connections here between the bones and the tendons called the vinculum, which are also important for stability, and then you've got the vessels around it. So when you get around joints, there's kind of a special mechanism that helps protect the tendon. You have really the volar plate here, which is a thickening of the volar capsule of the metacarpophalangeal joint, where the capsule attaches to the base of the proximal phalanx, and you can see a little bit of thinner, more proximal connection to the metacarpal diaphysis distally here. And you got the collateral ligaments, the sagittal band that we already talked about, which comes here, and then you've got this sheath surrounding the flexor tendon, allow it to flex and extend in the region of the metacarpophalangeal joint without injury from motion of the joint itself. And here's just a sagittal image showing that anatomy, where you can see the volar plate here, which is this structure, and the tendon overlying it. And of course, the sheath that envelops it is too thin for us to be able to differentiate here. And here's the flexor tendons going distally here. So, and then here we can see that anatomy here with the flexor tendons going through the area of where the volar plate would be. Okay. I forgot who was last. Why don't you take this?
All right. So looking, is this a coronal image or sagittal image? Sagittal image, right? I think we're looking at the volar plate of the first metacarpal. phalangeal joint, and it looks like there is
I think this is
the second. Okay. I kind of see there is a little bit of thickening centrally, and there's irregular signal. Is that an ossicle within the volar plate?
So it's not uncommon to get ossicles in the volar plate. I don't know if that's congenital, maybe, or sometimes it may be post-traumatic, like we've seen in other thickened tendons here. In this particular case, we have a tear of the origin here, the proximal aspect of the uh, volar capsule and its attachment to the metacarpal here. Typically occurred in hyperextension type injuries.
So we're looking at the PIP joint here. Looks like there's, again, a tear, the proximal portion of the volar plate, and there's some dorsal displacement of that phalanx, of the proximal phalanx.
And here's another hyperextension injury where we see a volar plate avulsion from attachment to the base of the metacarpal. And this particular patient also had a tear of the collateral ligament and obvious instability of the joint space there. Okay, Michael, what do you think of this case?
Okay. 23-year-old male, ulnar deviation after trauma and persistent MCP joint pain. So I'm seeing signal irregularity involving the proximal aspect of, I'm guessing that's the radial collateral ligament proximally, and there's a little bit of bone marrow edema too, so maybe like at least partial, maybe full thickness tear, avulsion of that collateral ligament.
Yep. Good. Which led to some deviation. Oh, sorry about that. I guess that is the thumb. Okay, and then there we can see it. So this is the area of abductor aponeurosis, and most of these occur at the attachment to the metacarpal, less more distally. Collateral ligament tears. Okay.
52-year-old male with pain along the radial aspect of the little finger after subacute trauma. See, there is a tear of the collateral ligament there proximally, and it's completely effaced. It doesn't look normal at all. Let's see. I don't know if there's a small avulsion as well, but looks like there's irregularity of that proximal cortex as well. But yeah, it just looks like a complete tear of that collateral ligament. And looks like there is the aponeurosis. This is like a synthetic Stenner lesion.
Yeah, so this is that radial collateral ligament here, which is pretty common on the little finger because it can get caught. It's less common on the other fingers. The fifth finger is out by itself on the edge, and this is a pretty common injury. And I've known several people who've had this injury. So it's a Stenner like there. When they're like this, my experience is that they're usually fixed. Though some surgeons are a little bit more aggressive and will even fix some that don't have the yo-yo sign on them. Here's someone who also had injury, and we can see a little traumatic cyst involving the subchondral bone there after trauma, a little bit of an injury to the proximal origin, and that was a hyperextension injury. Here's an old fracture dislocation where we're getting some degenerative changes which are developing. Okay, and then here,
Looking at the volar.
This is about a 50-year-old female who caught her little finger and had pain at the fifth metacarpal phalangeal base.
I'm seeing just a focal area of increased signal the volar aspect of that. And yeah, also radial aspect.
Okay, that was on 6/16/03. Here we can see, I don't know about like
Oops,
8 months later.
Right, it healed, or
Yeah. So in this particular case, I've seen these fixed with little tiny screws. I think I'll show one in a minute. But I've also seen a lot of these buddy taped to the fourth finger where they're just allowed to heal. And the one person I know well who had one of these fixed, they were symptomatic for almost a year afterwards. So, and the professional basketball players I've known who just had these buddy taped and never had surgeries were basically asymptomatic after about 3 or 4 months. So my inclination would be, unless there's a lot of displacement, would be to let these heal.
Is this the more common injury in basketball players?
It's a fairly common basketball injury because they hit it with a ball, kind of compress it. Okay. Michael, what do you think of this case?
Okay, 29-year-old professional hockey player, 3-month history, third MCP injury. So there's quite a bit of edema and even some linear low signal on the metacarpal head. So at least, like non-displaced acute trabecular bone injury. Then that collateral ligament does not look healthy.
Yeah.
I don't really see it at all, actually. So I'm not sure if that's a little piece of ligament kind of flipped down proximally, and if there is like some fracture of the metatarsal head, non-displaced.
So this patient had an ulnar collateral ligament avulsion. So for these middle fingers, this is pretty uncommon. This was in a hockey player. Most of these injuries are in the first. Quite a few of them are in the fifth, but very few of them are in between, but they do occur. Okay. 61.
The whole idea is to treat these early.
So
For some reason, I came out and then came back in. It took me a heck of a time to get back in, John.
Oh,
So
I was wondering why you were so quiet.
back. Yeah.
So 61-year-old female fell 2 weeks ago with pain with the radial side of the fifth metacarpal phalangeal joint. You could see that on the radial side of the fifth metacarpal, there's irregularity and detachment of the proximal collateral ligament, and I think that's Stenner lesion, or like a Stenner-like lesion with the aponeurosis there and being displaced.
And so this was an intraoperative view when they went in to fix this. There is the collateral ligament coming down and being placed there. This is pre-repair and this is post-repair. And then this patient, again, took him about almost a year before she was asymptomatic. Okay, this was a well-known NBA player.
I'm seeing increased signal on the radial side there, the fifth digit. Yeah. Is that the collateral ligament?
That's the collateral ligament. Here's the coronal arches.
Yeah, the distal attachment of the collateral ligament is affected.
This is the displaced collateral ligament right here. There you can see the collateral ligament. So this is really displaced. This is kind of like a stigma. This particular location. It was recommended that he have surgery. He refused, and we can also see that there's a little bit of a volar plate tear here proximally as well. So they buddy taped. Here's a they just buddy taped this, and he continued to play just with basically 3 fingers and a thumb on that side, but was asymptomatic after 4 months, and went on to finish his career.
Did they ever get a follow-up to see how it healed?
Well, the only follow-up I heard is that he had no symptoms after about 4 months.
Wonder how this would fix itself.
I think it just scarred in, just developed scar tissue between the two. And because it's the fifth, you don't have as much strain on it as the base of the first. So my guess is that most of these would probably heal pretty well, but I don't really know the literature on it. But except for my former wife, all the other ones that I've seen of this have not been operated on. Okay. Let's see, who did the last one? You did? Okay, Michael.
Okay, fifth MCP pain after injury. So it looks like we're doing an MCP arthrography. I've never seen this before, but we see quite a bit of so the injection looks like straight into the joint, and then you have contrast going, proximally and distally. So there's got to be complete disruption of that medial collateral ligament on the radial aspect. And it looks like there's probably a sprain of maybe even the ulnar collateral ligament to a lesser degree.
Okay. So that was a radiocollateral ligament tear.
It looks torn to me.
Yeah. And again, I think this healed without surgery. So then let's go to the
Most will, John, except you have to treat them right away.
Okay.
And that's the secret. And then treat them for a long period of time. What happens is they treat them for a couple of weeks and then remove the splinting or the buddy taping, and they have a re-injury. As you know, ligaments take a very, very long time to heal.
Right. Good.
You're talking about months, not weeks.
Yeah. Okay, and so here we can see the thumb, the base of the thumb, and we can metacarpal bone, proximal phalanx, and here we can see the capsule and the collateral ligaments here. And again, most commonly what happens is you kind of catch the thumb, you pull it out radially, and so you get an ulnar-sided tear. And so here's really the capsule and the collateral ligament here, and this is retinaculum that we'll talk about here in a minute. So there are the collateral ligaments. This is the aponeurosis of the adductor pollicis tendon over here, which is what this is, which will be an important structure we'll see here in a minute. And there's the ulnar collateral ligament. It's very difficult to tear the radial side. I think I may have one case of radial-sided tear, but if you press the thumb, it stops at against the palm of the hand on that side. Whereas if you pull it out, you can pull all the way out and tear the ulnar collateral ligament, which is a very common injury. So the ulnar collateral ligament over here, radial collateral ligament, and then here just the flexor tendon goes in through here with the sesamoid bones. And then also we have the dorsal anatomy, capsular anatomy and attachment, and the volar plate of the thumb as well, which can occasionally have a little ossicle in it in the flexor and extensor tendons. Then, depending upon the level. Now, the other thing that you have on the flexor side that we'll talk more about later is the pulley system. So if you curve your fingers or if you try to flex your hand, you notice that the flexor tendons stay up close to the bone. And as you know, the reason for that is that you have the pulley system, which are strands of fibrous tissue that go from bone to bone and around the flexor tendons, which don't allow the flexor tendons to bowstring. And therefore, even with flexion, they'll continue to pull in the proper direction. If you didn't have these, the flexor tendon would bowstring and displace from the bones when you started flexing, and then you wouldn't have them pull from the proper direction, and you would lose function in the hand. And these are what the pulley systems look like, and that's the flexor tendon, and here's the bone.
There are 5 of them.
Okay, and we'll go through this now. Let's go back to the thumb again. So with the thumb we have, this is the base of the thumb. There's the extensor tendon, flexor tendon, ulnar collateral ligament, radiocollateral ligament, and here's the adductor pollis aponeurosis out here, exterior to the ulnar collateral ligament, which we can see here. So when you tear, you can grade it in different ways, but basically there are really two grades. You either have a tear that's, well, or three maybe. You have a tear that's just, well, you get a partial tear where you're thickening and increased signal intensity. That's treated conservatively. You're going to have a complete tear of the ligament off the bone, which is the most common, and retracted, but the overlying retinaculum is intact. You can have a bony avulsion, which I've found is very uncommon in this location, or you can have a tear of the ulnar collateral ligament, a tear of the retinaculum, and then the ulnar collateral ligament displaces proximally and then can extend into the tear of the retinaculum, in which case if it heals, it will scar down to the retinaculum, not to the bone, and then this will be elongated and you'll end up with chronic instability. This is what's called a Stenner's lesion, which occurs somewhere around 20 to 30% of these injuries, and is generally considered a surgical problem. Whereas the bone avulsions may or may not be surgical, depending on how big the avulsion is. If you just have a tear of the ulnar collateral ligament off of the bone without a bone fragment with an intact retinaculum, then those are typically considered non-surgical cases where they're just splinted and allowed to heal. So we're basically
It depends on how much displacement there is, John. If you cannot replace the little fragment of bone, you put a little screw in there, okay, and fix it.
Good. So here's from the literature, a little minimally displaced tear of the ulnar collateral ligament in this location. It's not displaced. We don't see the typical findings of a Stenner's lesion, and it's typically a conservative lesion. Here's a little bit more of a distal injury. Again, in that location. Here is again a tear of the ulnar collateral ligament off the base of the proximal phalanx, not really displaced. The overlying retinaculum, I don't see the ligament proximally displaced or really balled up in this particular case. So that would also be a non-Stenner's type lesions. Here we can see kind of thickening in the region of the ulnar collateral ligament and increased signal intensity with some fluid and hemorrhage adjacent to it. That would be another tear. Now, so what we're looking for to determine whether it's surgical or not is if you have significant displacement, like John just said, of the ulnar collateral ligament. So here's a case from the literature where we can see that the ulnar collateral ligament has been torn off its attachment to the base of the proximal phalanx. It's proximally displaced so that the end of the ulnar collateral ligament is nowhere near the base of the proximal phalanx. And in fact, it's snug up against the retinaculum here, or the pollicis longus. And this is if this heals, it'll heal here, and obviously you'll end up with an unstable joint. So this would be a Stenner's type lesion and would be a surgical case. Ashley, what do you think of this?
I think this is actually a part avulsion of the ulnar collateral ligament distally, and you can see that it's displaced, kind of abutting the adductor aponeurosis, I think, along the ulnar side. But
you can see that there's some other injuries here as well.
There's leg injury.
This appearance has a name. This is called a yo-yo sign, where you can see kind of a thin, stretched out part of the ulnar collateral ligament, and then this would be the body of the yo-yo down here, where this is all just a stretched out, thin ulnar collateral ligament. If this heals, this will heal in an elongated fashion, so this is another type of Stenner's lesion. So the yo-yo sign is an indication for surgery.
Yo-yo sign reminds me of my start of my career when I was a boy.
Yeah.
Got me a bicycle in Detroit.
All right. Detroit.
850 loop the loops.
Oh my God. Very good, John. Very good.
I don't think our fellows know about yo-yos too much.
Have you guys used yo-yos?
We had a yo-yo pad.
I have to tell them one of these days.
All right. Now that these are big.
Yeah, I think yo-yos were big when I was in middle school.
Terrific. I used to run contests.
I think,
You
yeah.
got $1 an hour. That was enormous amount of money in those days. Anyway, I'm sorry to interrupt this lecture with the yo-yo.
All right. We got a hockey player checked against the boards, thumb pain. I'm seeing edema on the ulnar side, the MCP joint there. Yeah, concerning. Oh, is this another yo-yo? Yep.
Actually, it's a misnomer because the yo-yo doesn't come back when it goes down.
Okay.
And it should come back. That's what yo-yos are all about.
Unless you're like me and it never comes back up again. Michael.
Yep. Okay, so at the ulnar collateral ligament, it looks like it's torn and distally retracted, and that's probably it there. That little dot of hypotension was probably bundled up, and that assuming is aponeurosis and looks like a yo-yo on a little string.
Yeah, and it's also had a volar plate tear as well, which you can see there.
Oh yeah, on the sagittals through the thumb, you can see that the volar plate is disrupted proximally.
I also have a subluxation, which is, and the ulnar side is, and the radial side is also kind of pulled, isn't it, John?
Yeah, a little bit. This is kind of an oblique image.
Yeah, somebody grabbed his thumb and twisted it.
Yeah. So this was another unstable injury.
Here we can see, I think this is a non-displaced ulnar collateral ligament tear distally. There might be a small avulsion fragment right there, actually. That's a little bit edematous. You can see a volar plate injury and edema there as well. You can see the avulsion fracture much more clearly on this one.
Okay, we're seeing some edema on the ulnar side of the MCP. Yeah, lots of bone marrow edema there. The head of the MCP. There's some. I guess is it the phalanx that would be displaced?
Yeah, so you're seeing that there's instability of the joint space here.
Yeah.
It's not congruent.
Yeah.
A big tear.
That's a radial injury, isn't it, John?
I think this one is still the ulnar side, John. I think I do have a radial one coming up though. But it's hard to say with just these images because we need to have all the other images to make sure what side we're on. But
Yeah, it's sure hard to tell.
Okay, Michael, what do you think of this one?
Hypothenar male with thumb pain after dog bite. So it looks somewhat similar. It looks like there's probably a little avulsion fragment along the ulnar aspect of the base of the proximal phalanx. So
Good.
yeah, avulsion fracture.
You can see a non-displaced tear of the ulnar collateral ligament distally at the proximal phalanx, and there's also increased signal along the radial side, but that might be normal. Oh, that is the abnormality.
This is actually partial body.
Okay, okay,
This is actually completion of second.
okay.
This is a baseball player.
I couldn't hear you on that one, John.
Yeah, this was a partial volume artifact where we're not actually quite in the midplane of the ulnar collateral ligament, and here we can see a little strain of the radiocollateral ligament in this baseball player. Pretty uncommon injury.
40-year-old male with first MC protuberance after trauma. We're seeing increased signal in the proximal insertion of the radial ligament there.
So that's another. Okay. So why don't we stop here, and we'll move to other joints at our next time. Now tomorrow I have to go to Santa Monica to set up some research projects that we're doing with smog on the scanner. So we won't have lecture tomorrow, but we will again on Monday. All right. Thanks, everybody.
Thank you.
No, thank you.
John,
Yes, John.
drop by. I'll give you some limes if you want.
I'll give you a call. That sounds great.
All right.
Thank you.
You bet.